Greetings. I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to the ANA presentation of updates in quality of life in vestibular schwannoma, including the development of a new instrument with the team from Mayo Clinic. Dr. Michael Link and Dr. Matthew Carlson will introduce themselves in just a moment. First, I'd like to handle a few quick items. Captions are available for this presentation. You turn those on at the bottom of your screen. Also, a reminder to keep an eye on our social media, especially during ANAwareness Week, for the many ways that you can learn about the resources available and how you can be more involved with the ANA. As we always say, we're here to help, so we hope that you will access those opportunities. And now, doctors, if you'd like to introduce yourselves, you can get us started.
Good morning or good afternoon. My name is Matt Carlson. I'm one of the ear surgeons here at the Mayo Clinic.
And I'm Michael Link. I'm one of the neurosurgeons here at Mayo Clinic in Rochester, Minnesota.
We're very grateful to be given this time to present something that's very near and dear to our heart, and that's quality of life, specifically for acoustic neuroma or vestibular schwannoma. I'm going to bring up our slides here. If that's presenting okay. So as we talked about, the goal of this talk is really to talk about, give some background about quality of life as it pertains to acoustic neuroma or vestibular schwannoma, and then also identify some gaps in research that we identified and collaborated with the ANA and members of the ANA, patients with acoustic neuromas, to basically develop a new instrument that we hope addresses some of the concerns that a lot of people face when they are diagnosed or treated with this tumor. For transparency, we work at the Mayo Clinic and so are, of course, paid at the Mayo Clinic. And we work with the Acoustic Neuroma Association and have been funded. Several of these projects have been supported by the ANA and were made possible by research grant funding. So we're grateful for that, but we need to disclose that as well. So just broadly, The Matrix was one of my favorite movies. And I think that one of the main undertones of the Matrix is this idea that we're so indoctrinated or we're so involved in what we do every day that it's difficult for us to be flexible. We just accept everything at face value. It is what it is. And even though that there's probably a lot of things that could be different or could be innovated, or we could think about things differently. And when you grow up in a system of education, all you do is you think that way. And we've grown accustomed to it. And there's this idea that real innovation is kind of grown from being able to unlearn some of the things and being able to escape from this kind of fixed way of thinking. And so it's this idea of unlearning the system. And part of that has to do with listening to patients. A lot of times a patient will ask a question and it's so tempting to say, well, that doesn't really make sense to me, or there's no data to support that. But a lot of the times the patients are on to something. And a lot of the times, particularly when you hear it over and over, we really start to say there has to be something to this. And that was one of the motivations for basically refining or redeveloping or developing a new quality of life index. We heard a lot of things from many patients that historically, at least from a medical standpoint, we didn't make sense to us, but we hear it enough that we believe it's true. And these are major important issues for patients with vestibular schwannoma. And you'll see later on some of those items are built into our new instrument that we'll talk about. There's this idea in clinical medicine. Mayo Clinic actually became famous. What we're really well known for, at least in the late 1800s and early 1900s, is we were probably the first center to recognize the importance of specialization and bringing together specialists to provide comprehensive care for the patient. But so these are common aphorisms or statements by the Mayo brothers. But I think you could actually replace clinical care and you could put research in there too, and all of it would hold true. So the idea is just this idea that there's so much information that needs to be held in our minds to be able to do good clinical care or research that it's impossible to believe that one person can do it well by themselves. And it's really by joining forces with other people that are experts in different areas that we can provide the best care or perform the best research. This is our core vestibular schwannoma team, but in reality, it takes a village. And so and even this doesn't really cover everybody who has been contributing to a lot of the projects that we're going to be presenting here that really led us to develop the vestibular schwannoma, the Mayo Clinic vestibular schwannoma quality of life index that we'll talk about. And one person I think deserves special highlighting is Christine Losey. She's been a cornerstone of all of the vestibular schwannoma research that we've done. and a lot of the other research in general at Mayo Clinic. And I think it's important to recognize her for her work. So getting into the talk, first part is really background or context. So there's many ways to treat a small and even a medium-sized tumor, and all different pathways might lead to a good outcome for an individual patient. So what is the best treatment for a small or medium-sized tumor? There's very few things that are more hotly debated in ear surgery or in skull-based neurosurgery than the best management of particularly a small tumor, but also a medium-sized tumor. So a lot of times we'll look at the notes. A patient comes into our clinic and we did surgery on them, and we saved their hearing and we preserved their facial nerve and we took their whole tumor out. We call that the vestibular schwannoma trifecta. And so we're outside the room giving each other high fives. Great. We're really excited about the outcome and we're really happy about everything. But then sometimes when we start talking to the patient, they'll say, well, it's great you did that, but I have headaches and I have dizziness or I have tinnitus, and it's affecting my personal life and job. And from a patient's perspective, those things can be worse than having a facial paralysis in some cases and other things. And so we tend to focus on the things we feel like we have the most control over, even though there's all these other things that we call them less tangible, difficult for us to put our finger on them, but they're still very important to the patient. And that's really what quality of life in vestibular schwannoma gets at. It's this holistic approach to the patient and their well-being and how they interact with their life on a daily basis. So it goes beyond just facial nerve function, hearing, and taking the whole tumor out. There's much more to it than that. Historically, quality of life was not looked at in the medical profession, and it's really, I would say, in the last 30 years, been prioritized. But even if you look at patient-reported outcome measures in vestibular schwannoma, or outcomes in general, we still are focusing on the old things that are still important, but we're not giving as much attention to the other aspects that are probably still important. So hearing preservation, facial nerve function are always studied a lot, and they are important, but we still don't give enough. We don't examine tinnitus, dizziness, headache, depression, those sorts of things, which also significantly impact a person's well-being. So what separates people who have a good quality of life or not? One way we measure that is an instrument. So there are some things we can measure pretty well, like we can look at your facial nerve function, understand how it's working. But there are some things we can't measure ourselves, like your level of tinnitus. There's no such thing as a tinometer. And even pain falls in that bucket. We can't really directly measure your pain level. It's how you tell us. And we usually use a 10-point VAS scale, it's called. So to assess quality of life, there's no quote objective measure that we take a blood glucose level or blood level or something. It's how you report back on a series of questions. And so that's these questionnaires that have been developed over time. The SF-36 and the Glasgow Benefit Inventory historically were the measures that we would use to measure a person's quality of life. But unfortunately, they're very generic. They're made for every disease. They're not just made for vestibular schwannoma. And so, as you can imagine, a lot of the questions are very general, and they don't really pertain to a person with vestibular schwannoma. In most cases, asking whether or not a person can carry groceries or not is not really relevant to most people with vestibular schwannomas. This is some questions from the Glasgow Benefit Inventory, just to make the point that they're not very specific for patients with vestibular schwannoma. Recognizing this big shortcoming, the group of Schaefer at University of Pennsylvania developed the Pendant Acoustic Neuroma Quality of Life Inventory, which is a major step in having a disease-specific measure. So it's much more probably accurate or sensitive is the way to say it for patients with vestibular schwannomas compared to all those old measures that were very generic. So that's kind of some of the background. We're going to talk a little bit about our journey. This is a plumera flower. It's a Hawaiian flower, and we were in Hawaii at a conference a couple months ago. And I put this up there because this is a flower that you can basically break off any part of it. The stalk can dry up and you can replant it again and grow a whole new flower again. And I think about that a lot with our research. A lot of times one thing branches into another thing and gives a whole new life to a whole new project that we didn't even think about before. And a lot of this research that we're involved in, and particularly quality of life, we'll never have all the answers to in our careers. It'll continue to grow and be an important area of study for decades to come. So these are just some of the studies that have been published by our group over the last about 10 years that have led up to the point of developing the quality of life, the Mayo Vestibular Schwannoma Quality of Life Index. Again, credit should be given where credit is due. Not only did we have a great group of researchers, we received a lot of support from the ANA, but not just research support through funding, but also access to the Acoustic Neuroma Association membership. So patients with vestibular schwannoma, there's no way that we can make a good inventory about quality of life without asking a large number of people about their experience, not only the patients, but also family members and friends. And so through this collaboration, we've had an ongoing study with the Acoustic Neuroma Association enrolling many of the members. So just some data from that. What have we learned from those studies that we presented earlier, those titles? The first thing that's super interesting to us is, we talked about the Penn Acoustic Neuroma Quality of Life Inventory, that measure that's used to look at quality of life in vestibular schwannoma. It's a 1 to 100 point scale. So when you have a scale that's that large, you might think that a 1 or 2 points difference doesn't really matter, and you probably need a bigger change to really matter. What's really amazing to us is if you take a large number of people and you follow them before and after treatment and you measure on a 100-point scale, the total change on average is less than 1 point, which is crazy to us, which means that as long as you get good care on a population level, the patient's condition has a more of an impact on their overall quality of life than the treatment in general. There are some exceptions, like, for example, some people who have a tumor have a lot of angst or concern about having that tumor in their head, and sometimes removing the tumor through microsurgery alleviates some level of anxiety. But in general, it's pretty amazing that the patient symptoms or existing conditions impact quality of life more than the treatment itself. And this is a very powerful slide. I think it's one of our studies, one of our papers that basically showed that if you look at a person's journey with their tumor from the date of diagnosis all the way through their treatments and even years after that, the worst day in their whole journey for a lot of people is the day they're diagnosed. They've just been told they have a brain tumor, and that creates all this anxiety about death or incapacitation, like many brain tumors do, even though vestibular schwannomas don't do that typically. But it creates this anxiety, and it's only after time that you've lived with it for a period of time, observing it, or have had treatment, that some of that anxiety is alleviated. And so to us, that's really important. And that's one of the motivations of why we don't, particularly for very small tumors, why we don't recommend treatment right away. It's very helpful for most people to think about it a little bit and get past that initial period, sometimes of shock, being diagnosed with this condition. This is pretty interesting. A lot of times when a person comes in after they've been recently diagnosed, they might have a really prominent symptom. Maybe it's tinnitus, or maybe it's hearing loss, or maybe it's dizziness. And they'll say, I want whatever treatment makes that worst symptom the best. Which treatment's going to get rid of my dizziness? Which one's going to make my tinnitus better? Those sorts of things. And what we found, and sometimes they'll say, I'm actually don't have much symptoms right now at all, but my uncle has really bad headaches and I really don't want headaches. So what treatment is going to avoid that risk? And it turns out that as far as tinnitus goes, headaches, and dizziness, there's not one treatment that guarantees those symptoms are going to necessarily get better in a better way than another treatment. And so we usually don't hang our hat on one particular treatment to get rid of those symptoms. What's really interesting is this idea of, particularly for small tumors, is what treatment were patients most satisfied with? So we looked at the quality of life measures, but this study here just asked the simple question, knowing what you know now, are you happy you chose what you did for your treatment? Or another way of saying it is, if there was a friend or family member who had your exact same situation, would you recommend the same thing to them? And it turns out that overall, most people are satisfied with their treatment in hindsight. Over 85% or more were happy that they chose surgery or radiation or observation. But what's interesting is the group that was overall the most satisfied with their treatment choice was the observation group, 96% compared to 85 and 86 for surgery and radiosurgery. And what's really important is these are this study looks at patients with very small tumors. So this group of people in the study really could have any one of those three treatments. If you have a very large tumor, you're really only probably going to have surgery. But for the very small tumors, there really is equality as far as treatment, at least broadly on a large scale. Then we looked at the question of, so it turns out if you have radiation or observation, it's 85 or 86%, and if you observe it, it's 96% satisfied. Then we looked at the question of, what if you just had treatment right away? So you have your diagnosis and you get treatment shortly after, within the first 3 to 6 months. Or if you observe it and then you treat it after there's something that changes that makes you want to have the treatment, like growth of the tumor, for example. Or if you could continue to observe your tumor over time, that usually means it's not growing significantly. There's almost this dose-dependent relationship with those three things, meaning the closer it gets to longer observation, the happier the person is. So if you have upfront treatment, you have an 81% chance of being satisfied in hindsight. If you observe your tumor and then get treatment, you have an 88% chance of being satisfied. And if you are lucky enough to have a tumor that you could continue to observe and not need treatment yet, you had a 96% chance of being satisfied with your decision that you made. So just some key bullet points. As long as you receive care by an experienced team, patient factors rather than treatment probably most significantly impact quality of life. Symptoms that are present before treatment are perhaps the strongest predictors of what a person will struggle with afterwards. We'll say if you have very bad tinnitus before treatment, it might still be a problem for you after treatment. If you have very bad headaches before treatment, surgery or radiation will not make the headaches better by themselves. Don't choose a particular treatment strategy because you're trying to get rid of tinnitus or headache or dizziness. Constant dizziness and frequent headache they're not as common as hearing loss, but if you have them, they can be a bigger deal breaker for you. That's what we see from a lot of people responding to these instruments or these surveys. And a comprehensive approach to patient care rather than simply treating the tumor likely maximizes the best overall quality of life.
So to kind of summarize what Dr. Carlson was saying, I would say it was a surprise to us about all this sort of 10 years of data. You know, we surveyed hundreds and hundreds of patients, some retrospectively, meaning some of the data comes from people who had treatment, you know, on average 8 years previously, and some prospectively, meaning we started questioning them the minute we met them and questioned them for years to come. And it turns out that there was hardly any difference in the short term or the long term, whether they had observation, radiation, or microsurgery. And that was surprising to us. You know, so on the one hand, you're saying somebody who has a major intracranial operation feels the same as somebody who had basically nothing done in terms of things like their feeling about their facial function, anxiety, general health, dizziness, and so on, based on the only disease-specific quality of life survey, this Penn Acoustic Neuroma Quality of Life Survey, or PANQUAL as it's called. And I think there's a couple explanations why that may be. It could be that there actually is no difference, because humans are pretty darn resilient. We take what comes at us and we deal with it and we get on with our life. And so as a species, we're doing pretty well at finding a way to be happy and satisfied and get on with our life. Or it could be that the instrument we were using to try and answer this question, what's the best thing to do if I want the best quality of life? Maybe the instrument isn't sensitive enough to tell us. So we got thinking about this. And when we started all this, again, more than a decade ago, we would send out these surveys to all the patients that we would see and treat, and patients who wanted to participate through the Acoustic Neuroma Association. So we literally accumulated thousands of patients' data. And included in that, we asked patients, you know, make any comments that you want to make about your symptoms or treatment or so on. And Dr. Carlson and I, if you wonder, what do you do in Minnesota over a long, dark winter? Well, we would read all those comments and try and collate them into some kind of categories. And that got us thinking, maybe we need a better instrument. So we started down this process of developing our own quality of life survey. And as Dr. Carlson said, we know that these general quality of life surveys, which are used across a large number of different disorders, diabetes, hypertension, cancer, they don't do well at figuring out vestibular schwannoma specific symptoms. And in fact, when we gave those surveys to patients, and we gave those surveys to normal people walking around the United States, those surveys couldn't even tell us who had a tumor and who didn't. So those were no good. And as I mentioned, there was very little difference using the pan-qual between the three different treatment modalities. So what's the problem? Is it that there is no difference, or is it that the instrument isn't sensitive enough? So we developed our own, which I want to, without getting in too much detail, but to show you what's involved in this, I think is an important thing. So as Dr. Carlson mentioned, we have an amazing a group of colleagues. Christine Losi is our statistician. Nicole Tombers is one of our research nurses. Devin McCaslin is an expert in disequilibrium and dizziness. Aniket Soji is an audiology expert. And Melanie, of course, is with the ANA. And Kathleen Yost is an expert basically in surveys. So we have an expert here at the Mayo Clinic who helps us figure out what are the right way to ask the questions. So the first step is this content validity. And then the second step is this construct and convergence validity to basically prove that we're asking the right questions and we're asking them in such a way that we can get to a confirmed answer. So we started out with initially 539 patients who had filled out a 239-item questionnaire, which, if you do the math, gives you more than 128,000 data points to look at. And then, as I mentioned, we reviewed over 1,500 free text comments that patients had sent to us. And I know this slide is too small to read, but it just relates some of the statements that patients wrote in, many of which were really insightful. Like, for instance, patients would say to us, well, I'm having trouble concentrating at work. And typically we would have said in the past, well, we don't know why that is, or we don't think it's related to your tumor or its treatment because we're not really near the thinking part of the brain. But we heard that enough times that we thought, we got to get to the bottom of this. So we narrowed down those initial 239 questions or statements into 194 basically kind of feelings or concerns that map to 10 different domains. And then we administered that in a prospective ways to patients that we divided up into 20 patients that had an overall low or poor quality of life, 20 patients that scored medium quality of life, and 20 patients that scored a high quality of life on their previous pan-qual. And we asked, how does that correlate? And we narrowed it down to 69 items mapped to 9 domains. And then we administered that to 450 other patients. Again, some of our patients, some recruited through the ANA, divided up into low, medium, and high groups. And then we also included these disease-specific quality of life surveys, the dizziness handicap inventory, the facial disability inventory, the hospital anxiety scale, the PAN-QOL, and so on, so we could see what the correlation is between our prospective generated questions and what people had answered in the past, to try and get to the bottom. Are we asking the right questions about the right symptoms, basically? And then, of course, all of our quality of life can be affected by a lot of things, not just having a tumor. Like, for instance, it's cloudy and raining today in Rochester, Minnesota. So probably I would say my quality of life is a little bit worse than it was yesterday when it was 70 degrees and sunny, which is a rare thing where we live. So we actually asked patients to take it twice, separated by a couple weeks, to see, is it holding steady? And so there's a lot of statistical analysis that I'm going to confess we don't understand very well, but Christine gets it, and she can even explain it to us. So, for instance, when we looked at hearing, these are the statements we came up with, things that are actually practical more than do you have hearing loss, but I have difficulty hearing where sound is coming from, or I have difficulty understanding speech when I'm in a noisy environment, or my hearing problems cause me to avoid groups of people, things that are kind of real life. And interesting, all those statements, for the most part, grouped into one category, but a couple didn't. Like, my tinnitus interferes with my sleep actually more correlates to a pain domain than a hearing domain. So that was kind of insightful for us. So these are the final domains that we came up with: hearing problems, dizziness and imbalance, pain, discomfort, and tinnitus, problems with face or eyes, impact on physical, emotional, and social well-being, difficulty with thinking and memory, which again, we wouldn't have thought had anything to do with having an acoustic neuroma, but we heard it so often we felt it was very important. And then also we included a couple questions about, are you satisfied with the decision you made or not? And there's a statistical test called the Cronbach alpha test, which basically answers the question in a statistical way: are all the questions in this domain speaking to the category you want to address? And it turns out that all the question statements we came up with correlated very well. Those are very good numbers. And then another way to look at it is, are each of the questions or statements unique to that domain? In other words, you don't want overlap. You don't want the questions about face or eyes to overlap with the pain questions and so on. And it turns out that all of the statements or questions are very unique to each of the categories, because there's such a thing as what we call survey fatigue, where if you have to keep answering the same question over and over again in different ways, people just get tired of that. So we want to make the questions efficient, and we showed that we did that. And then, as I mentioned, we want to make sure that it's mostly getting to vestibular schwannoma or acoustic neuroma issues, that it doesn't have to do with whether it's sunny outside or somebody had a good day at work or something like that. And again, it shows the retest was very, very reliable. So we were able to develop this new instrument. We think that the questions are frankly, or the statements are much better in terms of getting to the things that we really want to get at. And we wanted to make it available not only in the United States, but frankly, worldwide. And so we partnered with the Journal of Neurosurgery, one of the big journals in our specialty, to translate our new vestibular schwannoma quality of life questionnaire and then publish it and make it open access so anybody could use it. And it turns out this was also a lot more complicated than we thought. So I thought, okay, if we want to translate it into Spanish, one of our colleagues, it turns out, grew up in Spain. We could just give it to her and she could tell us what all these words mean in Spanish. But it turns out that it's a much more complicated process because there's a lot of cultural differences in how language is interpreted. For instance, one of the questions might be, I have trouble walking around my house to indicate a problem with dizziness. And I suspect most people, English-speaking people, understand what I mean. But one of our patients from Norway replied, well, I live by the sea, and if I tried to walk around my house, I would fall in the ocean. So it's a different interpretation. But fortunately, there's a company that helps with all of that, where they can back translate it into English and get native speakers to review it. And then we could give it to some vestibular schwannoma patients from those countries and verify that, in fact, we have good translations. So we were able to do that. We now have it translated into Arabic, French, Japanese, Norwegian, simplified Chinese, mostly Mandarin, Spanish, German, Italian, Ukrainian, and it's coming in Dutch and Czech as well. So we've created this new 40-question questionnaire, which takes about 8 to 10 minutes to complete. And just like the PanQual, it's scored 0, meaning the worst quality of life, and 100, the best quality of life. You know, and it took us almost 2 years to complete this and cost around $32,000. It's now available in 10 languages so far, and we made it open access, meaning anybody can access and use it for research purposes. And our big question is it going to find that there are, in fact, differences in quality of life between the 3 treatments? And most importantly, can it help us establish improvements in domain-specific or global of quality of life outcomes among treatments when stratified by specific features, like a patient who's really dizzy or a patient who has a lot of tinnitus? Because for us, that's kind of the holy grail, or where we seem to not be able to answer that question. So that's kind of the journey that we've taken to get to this point. We're extremely grateful to all of you, the members of ANA, who have helped us get this far. And we hope we continue to make progress in this realm.
Dr. Carlson and Dr. Link, thank you so much. That was terrific. I appreciate the recognition of the ANA, and your entire team is very professional and gets very deep into this research. So we really do appreciate all that you've done. We have a couple of questions. If you still have some time, if you want to stop sharing your screen, it'll just be us on there.
Sorry, my mouse is a little...
All right. How far out of treatment, or at what point along the way are you asking patients these questions? For instance, if they have treatment, how long until will they fill this out?
So there's really 2 aspects to all this. So one is we did what we call a retrospective look at this, where we just asked patients, no matter how long ago you were diagnosed or had treatment, please fill this out and send it in to us. Many years ago, 5 or 6 or so years ago, we started to prospectively do it, where everybody we met, we said, please fill this out. And then we did it 6 months for the first year, and then yearly for the next 10 years. So we plan to have good longitudinal data as well as some long-term prospective data.
How many patients, you mentioned when you first started this, that there were 539 patients to start. How many patients have gone through it, would you say?
That's a great question. I think collectively, so the cohort comprises respondents from the ANA membership, and also patients are recruited through our clinic as well. And cumulatively, I think I'll have to ask Christine, but I think we are now over 2,000 people who have touched the survey. Some of them prospective, like some of them multiple times. But if you count people who have at least touched it once, I believe it's over 2,000 now. And so your question is very good. If you look at some of the published research, we have a lot of patients that will come in to clinic and they'll actually bring a paper along or ask a question that clearly shows they've read that paper. If you look at something that's cross-sectional from published by our group. That's what Dr. Link is referring to as it's kind of a potpourri of different time points, varying time points. If you look at the prospective ones, they're controlled for the point of follow-up. So that we'll say before treatment, 6 months to a year after treatment, so on. And so in general, we think in medicine, the prospective ones have a little bit better data than the cross-sectional, but they're both valuable in their own right.
Is this something, last question, is this something patients should, if they're not at the Mayo Clinic, should they be asking their doctor to fill this out, or how else would they, are you seeing this being picked up by other medical centers?
Yes, it is commonly used. I think increasingly people are recognizing the value of this, and it's just it's an additional measure that's often been historically overlooked, and people recognize the value. I mean, basically what this is asking, it's not like looking at their facial nerve function. We're just saying, how are you doing in all these areas of your life? And that's really important. That's the practical rubber meets the road. How are they really doing? So there's two ways a center could do this. They could either distribute it themselves, either for clinical or research purposes, or they could just direct people to the ANA website and recruit through there, and we would capture it and report it separately. So either ways, it would be reasonable ways to participate.
Yeah, no, we promote it on our end. We think this is terrific research, and we really appreciate you doing it. Thank you for this, and please thank the team back there. You mentioned Christine a couple of times. She's, I know everyone's a professional. We deal with Christine quite a bit. So you've got a terrific group over there. Thank you for all you do for ANAwareness Week, and for all you do as partners with the ANA. We really do appreciate it.
Thank you. The feeling's mutual. You guys have really made a lot of this work happen through funding, but also access to the very large number of patients that you serve. So thank you.